I'd like to now ask Dr. Socinski about 2013, what should be the molecular tests that we're doing? We've already alluded to this a bit, but should it only be EGFR mutation in ALK? Should we include KRAS? What about other tests?
Well, I think from an actionable point of view, it really is EGFR mutation because, again, we have, in my opinion, a new standard of care in that population in the first-line setting. The EML4 ALK, we have some evidence, not necessarily in the first line, but in second line, that a targeted approach with crizotinib is better than standard chemotherapy. I personally believe that that will be also true in the first-line setting. And if I understand the guidelines currently, they don't necessarily distinguish line of therapy in terms of use of crizotinib in an ALK-positive population. So that would be the two major categories. I struggle with how KRAS status should influence what I do. We do it routinely at our institution because as part of the Lung Cancer Mutation Consortium, we have a KRAS trial, and that's how we identify patients. I would strongly encourage practitioners to think about ROS1 in the right patient. It is about half as common as ALK, but if I had a younger patient, never smoker, who was wild type for EGFR and negative for ALK, then I would consider doing ROS1 in that setting because, again, the activity of crizotinib is mirroring in the ROS1 population what it is in the ALK population. So those would be the three things that I would think of in day-to-day practice right now.
Another issue, Anne, did you have a comment as well?
You know, I actually would also throw in BRAF mutation as well, just because we have an actionable target with that.
Well, yeah, I think there's, and we do BRAF, and the reason is because we have a clinical trial with a BRAF inhibitor, and that's why we're doing RET and a few others to identify patients for trials. And I do believe that with time we will have evidence that when you molecularly define a targeted population, that a targeted drug at that molecular defect is going to be better than standard cytotoxic non-specific chemotherapy, if you will. That's my bias. And that's borne out with EGFR and ALK so far. So I think it may be true in other settings. So I don't disagree with that. However, in day-to-day community practice, you know, I guess we should think of that if you come up negative on the initial screen.
I think in day-to-day community practice, the two crucial tests are EGFR and EML4 ALK. We'd all agree on that. Like you, we will test for KRAS simply because we have clinical trials, but it's not yet an actionable marker. If those three are negative, and lung cancer now has its triple negative, just as breast cancer has, we'll then go to the second tier, and we'll include ROS1, BRAF, and actually on occasion HER2.
Yeah.
So would the panel then agree that this guidelines, for example, and what we test for today, all of this is rapidly evolving? So probably a year from now or 2 years from now, if we came back to this conversation, we might have more concrete evidence for some of the other markers.
Absolutely.
Right.
Absolutely.
And actually, if I could ask, Corey, you implied that you are testing that you would test for the first 2 or 3 EGFR, EML, ALK, plus minus KRAS, and would you save tissue to test for others later? Are you doing it in that fashion, or?
We're doing it sequentially. I think this brings up one of the other important questions. Do we do it all concurrently, or do we do it sequentially? Tissue is precious, and it's easy to deplete it, so sequential testing is more likely to do that. Plus, patients are ill. They don't have the time to wait for all these results. So it makes sense, at least in my mind, to assay for the most actionable markers, and those clearly are EGFR and EML4 ALK. And because we have studies, and again, this may be an academic bias for KRAS, the other markers are relatively rare, 1 to 2 to 3% at most, so we'll generally do that as a second tier, but on the same specimen.
Although rare, you know, finding them, you know, I have a personal experience with a gentleman who was about to go on hospice, and we detected ROS1 translocation, and he's now 10 months into a very robust response, back to work and having a very quality of life. So if you find it, it can make a huge difference in the life of a patient.
Absolutely.
I like to speak to my patients in analogies because they can then put the information in perspective. So during baseball season, Mark, I will tell them, for example, if we find this abnormality in your cancer, like ROS1, then we've hit a home run. So again, it can be very meaningful on an individual patient basis.
Right.